Dr. Johnson, thank you so much for joining us here on MD Newsline Podcast. Can you please introduce yourself to our audience?
Sure. Thank you for having me. My name is Amber Johnson. I'm an assistant professor of medicine in the section of cardiology, Department of Medicine at the University of Chicago, and I'm a general cardiologist.
Wonderful. And today we're going to be talking about cholesterol. I'm really interested to find out how has the epidemiology of cholesterol and ASCVD risk changed over the past decade in your practice?
I would say that we are more aggressive about treating cholesterol and testing for cholesterol than we have been in previous decades. We have the data, years, decades of data that show us that LDL cholesterol, which is considered the bad cholesterol, is linked with cardiovascular events. And over the past decade, we've been more aggressive about trying to get those numbers lower.
And among your patients, which lipid abnormalities like elevated LDL-C, non-HDL-C, triglycerides, things like that, are driving most of the residual cardiovascular risk that you see?
Yeah, so when you look at the risk scores, a lot of them, most of them include LDL cholesterol. That really is the main target that we focus on because we know that it's associated with outcomes. And then also because that's what our medications can treat. We have other medications that can help with different things such as triglycerides. However, when you look at the risk scores, triglycerides are not often part of the risk calculator. We also look at HDL. We know that higher HDL is considered a risk reduction factor. But again, not a lot of medications that are able to increase HDL. One other risk factor that I sometimes will test, especially for women, is a high sensitivity CRP. There's another risk score that specifically adds the high sensitivity CRP. That's the Reynolds risk score. And that one has been validated to predict cardiovascular events for women.
Hmm. Interesting. And to what extent are current population level cholesterol control efforts translating into actual achievement of guideline recommended LDL-C and non-HDL-C targets?
That's a good question. From a primary prevention standpoint, and also just thinking about what we can do at the population level, we will often begin by lifestyle modification. Leading a heart healthy lifestyle is something that we encourage for all patients. And organizations like the American Heart Association, for example, has something that's called Life's Essential Eight. I believe some of my colleagues have spoken about that previously. It's actually a very commonly used tool that the American Heart Association promotes that talks about 8 different things that we should be focused on when it comes to preventing heart disease. One of those things is lowering cholesterol if you do have a elevated cholesterol, but the lifestyle factors include incorporating more physical activity, eating a heart healthy diet, making sure you're getting good sleep. If you smoke, quit, and those sorts of things. And so I think we are becoming more cognizant of the things that we can do on our daily basis just to prevent the development of heart disease.
Mm. Um, and I want to switch over just to talk a little bit about guidelines, risk assessments, and targets. I'm wondering what are some of the key changes in the 2025 ESC EAS focused update on dyslipidemias that you think practicing clinicians need to kind of focus on?
Right. So the European Society of Cardiology had issued some guidelines in 2019, I believe, and then they did a focused update this year where the main things that changed were the targets for LDL. So, for example, for depending on people's risk, if you're at very or extreme risk, I think is the category that they classify, which I think is about like greater than 20% risk of cardiac event plus having had a history of cardiac disease or peripheral artery disease. For those folks who are at extreme risk, they recommend getting LDL cholesterol less than 55, I believe, or even lower than that. And so, really moving towards, as I was saying before, aggressively treating LDL cholesterol and lowering it as much as possible. Another thing that they talked about in the updated guidelines were some of the newer therapies that we're using, including the PCSK9 inhibitors, which help to lower cholesterol, and thinking about other adjuvant medications that you can use in addition to statins or instead of statins for patients who are statin intolerant. And then one other really big thing that they talked about in the ESC guideline, and I think that our American guidelines will probably incorporate as well, is measuring lipoprotein little a. So there's been a lot of data that's been coming out since the 90s, if not before, but we know more and more about how LPA is linearly associated with cardiovascular disease, and that's irrespective of LDL. And so, at least screening for LPA as a risk modifying effect in all patients who are at risk for heart disease.
Mm. And how do you integrate different risk calculators into decision making around lipid lowering intensity?
Yeah, so that's a really good question. I think that this is really for patients who we're talking about primary prevention, because once somebody's had a heart attack, once someone has peripheral artery disease, or if they've had a coronary calcium score that is elevated, at that point we really need to have them on medications, and there's really no question of whether or not the medications are indicated. However, for patients who maybe have not had any history of heart disease, but maybe they have risk factors, including family history, or if they have diabetes, hypertension, obesity, metabolic syndrome, those are the folks where we'll do a risk calculation and we'll try to determine whether or not they need to be on a lipid lowering therapy. And usually, what the answer comes down to is how intensive their statin dose should be. For folks, if we put in their numbers and find that their risks are low or intermediate, then we start to think about other ways that we can essentially convince ourselves whether or not they need to be on lipid lowering therapy. And so that might incorporate use of screening tools like a coronary calcium scan, or even stress testing, depending on if someone has symptoms or not.
Hmm. And how would you say how have updated endocrine and diabetes society recommendations influenced your thresholds and targets for lipid therapy in patients with diabetes?
Yeah, so for folks who have metabolic syndrome, diabetes, obesity, hypertension, they are in a high risk category. And sometimes when we plug their numbers into a risk score calculator, we may not find that their risk is actually high compared to our clinically suspected risk. And usually, what that has to do with is their blood pressure and their age. So, for our younger patients, we are less inclined to treat them with lipid lowering because their age just doesn't put them at that category of being elevated. For those patients, there's a number of different things that I might consider. Again, talking about lifestyle modification and preventing heart disease, weight loss through physical activity and heart healthy diet. Those are things that I pretty much talk to all of my patients about, but I try to, be a little bit more encouraging for patients who have metabolic syndrome. Another thing that I'll consider is thinking more about weight loss. So, GLP-1 agonists are very hot right now, but for very good reason, because we know that by losing weight, by getting into a lower weight category, a lower BMI, that we're able to mitigate so many devastating effects that obesity can cause. And so a lot of times I'll work with my primary care colleagues, I'll work with my endocrine colleagues, weight loss specialists and nutritionists to think about medications like GLP-1 agonists. And then in addition, in my patients who have diabetes and are at risk for kidney disease, or if they have some screening tests that come back that show some kidney damage. And so by that, I mean a creatinine or cystatin C or a urine albumin creatinine ratio. If any of those things are flagging as a little bit elevated, those are the folks that I'm more aggressive about getting them on SGLT1 inhibitors. And so, trying to prevent the development of renal disease or diastolic dysfunction.
Mhm. And I just want to talk a little bit about statins specifically. So, despite extensive evidence, what are the persistent barriers you encounter to appropriate statin initiation and intensification?
So, a lot of times folks have heard negative things about statins. Maybe they had a friend who was on a statin and couldn't tolerate it. Statins are one of the most commonly prescribed medications, and a lot of folks have tried them at one point and stopped for various reasons. There's a lot of debate as to whether or not the side effects that we see from statins are, quote unquote, real or not. There's actually some trials out right now where patients are being enrolled and randomized to either a statin or a placebo to try to understand if the side effects that they're experiencing are truly side effects, or if they are actually on the placebo and saying that they're experiencing side effects. So the side effect from statins is a real concern, in the sense that folks may not take them if they feel that they're having a side effect. But there's also a lot of rhetoric and fear around taking statins that maybe is a little unfounded.
Mm.
So, aside from side effects, sometimes I will see that folks will will start taking the statin and then will stop for reasons such as cost. Sometimes, if someone's insurance changes, then they may no longer be able to afford the medication. Or, nowadays folks are deciding whether or not it's worth their money to spend on a prescription medication versus something else. And so there may be some competing priorities. And then also, polypharmacy is a big concern, especially for my older patients or patients who have a lot of comorbid diseases.
Mm. And how do you approach reported statin intolerance, and which strategies are most effective in your experience?
So, what I'll usually try, I'll look at the dose, I'll look at what type of statin they're taking. If it is a statin that is not particularly potent, then I may switch them to a more potent medication. So, maybe rosuvastatin instead of, what they had previously been taking, with a thought that perhaps we can get away with a lower dose of the more potent statin. And we'll see how that's tolerated. Switching to from one statin to another is also an idea that folks will usually try just to demonstrate if it truly is statin intolerance. And then sometimes we'll try alternative day dosing, so maybe every other day or 2, 3 times a week, just to see what if we are able to get any statin on board. And then it's a little bit of trial and error, because you have to then check the LDL levels again, check the lipid levels again, check their complete metabolic profile, make sure they're not having any signs of liver dysfunction. And so it does take some time to finally get to a dose that is tolerable. And then you have to determine if the effect is strong enough, or if maybe you need to add an adjunct therapy.
Yeah, and just kind of think about non-statin LDL lowering therapies. How do you sequence things like ezetimibe, bempedoic acid, PCK9, and all of those other things? How do you sequence those things in statin intolerant or very high risk patients, um, not at LDL-C goals?
Yeah. So oftentimes I will add a non-statin medication to a patient's statin dose if they are not at goal. If a patient is statin intolerant, then I could try an alternative therapy instead. And the reason why we do it this way in clinical practice is just because of what insurance companies cover, quite frankly. And we want to make sure that our patients are able to afford the medications that they're taking. And so you have to sort of demonstrate statin intolerance by this trial and error process that we just talked about. And if someone does truly have statin intolerance, then that's the point at which you would consider adding a PCSK9 inhibitor, which we know are a lot more expensive and may also have some barriers from the patient perspective, aside from cost, with regard to having to do injections, so weekly or biweekly injections, if you're using the monoclonal antibody PCSK9 inhibitors.
Mhm.
But specifically to answer your question about the bempedoic acid and the ezetimibe, uh, both of those medications are effective at lowering LDL-C cholesterol. However, the effect is not as strong as a PCSK9 inhibitor. And so, usually, if you have a patient who is high risk and you want to be very aggressive about lowering their LDL, oftentimes it does come down to having to consider the PCSK9 inhibitor.
Mhm. And then 2025 ESC EAS update specifically highlighted bempedoic acid and evinacumab. In what clinical scenarios are you finding that these agents are most impactful?
Well, I would say the bempedoic acid is an adjunct therapy at this stage, at least in my clinical practice. And so usually I'm reserving that for patients who, again, if they have a statin intolerance. Um, I've had some patients where we've considered adding ezetimibe. Sometimes folks who have statin intolerance will also have ezetimibe intolerance, but the bempedoic acid may be more beneficial. I've not used any of the other therapies that the ESC has recommended.
Mhm. Does any case come in mind that might illustrate when you would favor, say, siRNA approach versus a non-clonal antibody?
Right. So the siRNA, that's the small interfering RNA, that is also a type of PCSK9 inhibitor. Its mechanism is just slightly different in that the dosing it does not require every week or every other week dosing. And so the way that it works in my clinical practice is if I do prescribe this medication, so specifically inclisiran, that it is administered in our clinic, in our infusion center. And so the patient will get their first dose. We make sure that they're tolerating it. The most common side effect is injection site reaction. Sometimes folks will have some minor joint aches and pains, similar to how they may have reported with a statin. But in relation to the statin intolerance, usually it's more well tolerated. So they get their initial dose, we monitor, and then a month later they get another dose, and then 6 months thereafter, and then it's every 6 month injection.
Mm-hmm. And how are cost and access influencing your non-statin choices, and what strategies help navigate payer restrictions?
It's challenging. It really is case by case. I am fortunate that we have a strong team of pharmacists that I work with, and so oftentimes, if there's any questions or if there's a prior authorization requirement, then I usually will reach out to our PharmDs to help figure out what will work best for the patient.
Mhm. And let's just go like beyond LDL a little bit. How do you currently measure and interpret remnant cholesterol and triglyceride-rich lipoproteins in clinical practice, if at all?
Yeah, so usually I'm getting a baseline lipid panel as screening for my patients. And so that's going to include your LDL, which is usually calculated unless you get a direct LDL. It's going to include your HDL, your non HDLs, and triglyceride, and your total cholesterol. So the triglyceride often gets ignored, unfortunately. It's hard to know exactly what to do with triglycerides when it's mildly elevated or to what extent that will increase someone's risk of developing heart disease aside from just the LDL. Oftentimes, our risk score calculators will not include triglyceride in the calculation. However, when we're seeing triglyceride levels that are in the thousands, so greater than 800 or 850, but definitely in the thousands, then that usually is a marker of familial hypertriglyceridemia or familial chylomicronemia. And in those cases, usually those folks would have presented prior to seeing me. I'm an adult cardiologist, and usually the folks who have FH or FC, usually those folks will present in childhood with pancreatitis because having severely elevated triglyceride levels can increase your risk of pancreatitis. And so by the time that they present to me, usually the familial cases have already been evaluated. However, when someone's triglyceride is mildly elevated, then I'll have a conversation with the patient about what we should do. Definitely lifestyle modifications are important. One patient in mind that I'm thinking about, we talked about his diet and particularly sweets. He noticed just from having checked multiple times that if he has a diet high in sweets, then his triglyceride levels were higher. And so I worked with him to try to get him on a modified diet that was heart healthy, including lowering his carbohydrate intake. And through that, he was able to get the triglyceride levels a little bit lower. But then we also added a medication. We added a fenofibrate. We still have to check his levels, actually. I think he's due for another level check. And if his levels are still elevated, we would probably include another medication called icosapent ethyl, which is a type of omega-3 fatty acid.
Mhm. Wonderful. And what is your view on merging agents targeting ANGPTL3 and APOC3 for hypertriglyceridemia and mixed dyslipidemia?
Yeah, so there are some newer medications in the pipeline. I believe there's one FDA approved medication available currently, and then there's another that's in development, which are ApoC3 inhibitors. And so they can help, particularly for the patients who have familial chylomicronemia or familial hypertriglyceridemia. I don't have a lot of experience in treating patients with those conditions, but the data suggests that if by lowering the APO the C3, that we can drastically reduce the triglyceride levels.
Mhm. So let's talk a little bit about lipoprotein A. How has routine LPA screening evolved in your practice, and how do you prioritize for testing? And who do you prioritize for testing?
Yeah, so if you look at some of the guidelines, including the ESC guidelines and the National Lipid Association guidelines, their updates for 2025 and 2024, respectively, both of them recommend checking LP little a in patients routinely. And so these would be all comers. Everyone should just have one checked at some point in their life. We are not at that point yet in our clinical practice. The majority of the patients that I see, I would say most of them have never had an LPA checked. And these are folks who, by the time they get to a cardiologist, they probably have some sort of heart disease. Some of the patients that I see have not had heart disease yet, and they're just seeing me for primary prevention. Um, I've gotten into the practice where I do check it on pretty much all of my patients. And so the information that I get back from it differs depending on what the patient's risk factors are. So, for example, a primary prevention patient, I would be checking an LPA just to try to understand what their risk might be, to help counsel them on lifestyle modification, and, pretty much go from there. For a patient who has had disease, who has had a heart attack, or who has peripheral artery disease, those folks, honestly, the LPA is probably not as useful at that point, because we would be more in the secondary prevention category. And so we're doing all of the things that we need to do to treat their heart disease. The challenge right now is that we don't have any medications that specifically target LPA. The PCSK9 inhibitors can lower it some, and the data suggests that PCSK9 inhibitors are so effective because they do help to lower the LPA. However, their lowering of LDL is really the main target that we focus on with the PCSK9 inhibitors. There are probably 3 or 4 trials going on right now, which are going to show us the effect of LPA lowering on cardiovascular outcomes like MACE. And so we're all very excited to see what those data will show. I suspect that it's probably going to have a positive result, because we know that LPA is linearly associated with coronary events and aortic stenosis. So I'm very excited to have some treatments for LPA soon. By the time that they're available, it'll probably be another 3 to 5 years from now. But it's pretty exciting to see what those results will show.
Mm. I want to talk a little bit about special populations. What are some key considerations for things like lipid management in patients with chronic kidney disease or those on dialysis?
So, for patients who are on dialysis or who have CKD, I pretty much treat the renal disease as a cardiovascular risk factor. And in my opinion, I think that those folks should be aggressively managed for their LDL cholesterol, and we should really try to get the numbers less than 70, if not less than 55, for their LDL.
Mhm. And in patients with HIV, inflammatory diseases, or things like cancer receiving targeted therapies, how do you individualize lipid management given drug-drug interactions and competing risks?
Right. So statins can often interfere with um, the antiretroviral therapies for patients with HIV. And the effect is such that the statin level is increased. And so that can increase your risk for myopathies. For those patients, the medication that should be prescribed, the statin that should be prescribed for patients with HIV is pitavastatin. And I don't prescribe it often, but I for patients with HIV, that should be the one that we are prescribing.
Mhm. And let's talk a little bit about kind of future directions in research specifically. There's a growing interest in this, what could be potentially a one and done or long acting lipid therapy, including things like gene editing. I've heard a lot about CRISPR, for example. How do you see these fitting into future treatment landscapes?
That's a really great question. I think that the future is very bright when it comes to CRISPR and Cas9 therapies. I'm a health equity researcher, and so I try to be practical. What role will these medications play in my patient population? I'm not quite sure. We've got a lot of room to improve on lifestyle modification, on making sure that people have access to healthy foods, to making sure that medications that are actually generic are actually affordable. And so the gene editing therapies, I think, have a lot of promise, but it just seeing how it plays out clinically, we still have a long way to go, especially as it relates to equitable care.
Mm. And from a systems perspective, what has worked best when it comes to improving long term adherence to lipid lowering therapies, such as like clinical workflows, pharmacist led clinics, digital tools, or other models? Is there anything that you found that is particularly effective?
That's a challenge. So adherence to medications, I think, is multifactorial. There are patient behavioral considerations, just simple things like making the medications part of one's routine, using things like pill boxes and reminders and apps. Those sorts of things may be helpful. Also, from a clinical perspective, so involving our pharmacists in the care of our patients. So, at the point of sale, in the pharmacy, that we're encouraging patient adherence, that there are different reminders and workflows such that medications get refilled in a timely fashion. And that also our pharmacists can help us in titrating medications too. We've seen that in the hypertension space. So if we're not at the optimal dose, that we can work towards getting there. And then for the clinical workflow for physicians and my colleagues in primary care, I think just making sure that we are staying on top of the medications that we're prescribing for our patients. And so we just mentioned drug-drug interactions, and so MedRec is so important, and there's so many opportunities that we have to do a good medication reconciliation. And unfortunately, it doesn't always happen as it should. And so, when patients are coming into clinic and when our MAs are rooming the patients and just making sure that things don't fall through the cracks, those are all ways that we can make sure that our patients are taking the medications as they should be.
Mhm. And when it comes to things like research, are there any ongoing outcome trials or areas of research or mechanistic studies in lipidology that you're watching closely or you're excited about?
Yeah, so I'm really excited about the trials that are looking at the LPA outcomes. And so there's the Ocean trial, there's the Horizon trial. Both of those are looking at medications that directly treat lipoprotein little a. And the outcomes include clinical outcomes like cardiovascular disease outcomes. And I believe some of the sub studies are powered to look at other outcomes like dementia and cognitive function. So it's really exciting to see what treating LPA will do clinically.
Mhm. For non cholesterol specialists listening, internists, hospitalists, endocrinologists, what are the one or two paradigm shifts in cholesterol management they most need to internalize right now?
Well, I think going back to what we talked about earlier, and just with the latest guidelines talking about lower lipid targets, I still have patients who will come to me concerned because their lipids are too low. You know, how low is too low? And the answer is there is no too low. Sometimes folks, the different treatments will have sort of a J-shaped curve, which at the lower end, the risk kind of goes back up again, and we don't see that with lowering LDL cholesterol. And so from a cardiovascular perspective, it really is safe to lower cholesterol as low as possible. So that's one paradigm shift. And then the other, I would say, is screening with LPA, because it's not routinely done for most patients. I think it helps to guide a conversation about future cardiovascular risk.
Well, Dr. Johnson, this has been an amazing conversation.
Yeah, thank you for having me.